I assume that I have not been invited for my medical training. I'm sure that I could not add some valuable things on that topic. I think I have been invited because I run IGES and because I'm teaching students in industrial economics. My talk is on will cancer drugs attack the sustainability of social health care. And I'm referring on a discussion, a debate, a very emotional debate in Germany on the question of if novel cancers are ruining the social health care system. And there are a few assumptions on novel cancer drugs that have been assessed in a study I'm going to be present here now. One of the assumptions on novel cancer drugs is that they are going to be used inflationary, and we just at the end of the discussion we had that issue coming out. The other assumption is that there will be an availability of a big number of cancer drugs, that the pipelines will deliver all sorts of new drugs that will fill in the repository of available therapies and will cost enormous amounts of money. Another point is that cancer drugs are considered to have prices that are so high that they are considered to be obscene, and that they will cause this will cause an avalanche of costs, and will be an attack on the sustainability of social health care. I found that the discussion in Germany is not a singular discussion. The Lancet Oncology Commission issued a paper last October, which has in its summary, which shares at least 4 points that are tackled in the German discussion. It's the increase of expenditure, the rapid technological innovation, overutilization, and the aging demographics. And therefore, I think the study on the German healthcare system has something to say also for other countries, in a similar economic situation. The study is based on data on the German drug market, which is covered by the social health insurance, which covers around 90% of the population. That means around 70 million people. The data are from 2010, and we made estimates until 2013 and adapted the data in 2011. So 2011 is confirmed by reality. I come to the first point. Are cancer drugs going to be used inflationary? First of all, I want to show you the proportions between common drug, simvastatin, which is given in a volume that can serve for 3.2 million people per year. And on the other side, we have cancer drugs that are given to 5,000, 1,500, 100 patients. If we calculate patient years, the real number of patients is somehow higher because many patients don't get it for the whole year. But these are calculatory patients. So the very important thing is that we are talking about very, very tiny numbers of patients compared to a population of a country. And imatinib is an exemption because imatinib is so successful that it produces the number each year a number of 500 patients, adding to the number of patients that are already there, because these patients survive and do not die, and they are kept patients for the drug. And we can see this also if we look to the development curve, the growth curves for single drugs, and we see that only 3 of them show continuous growth. The others show, after 5 years on the market, they show already a flattening curve, which means that there is no more uptake of these drugs in the population. That means that the population that is eligible for this is saturated by this drug. So there is no inflationary use of these drugs from this side. Some people fear that the development, the aging society, the development of demographics is something that fuels an exponential use of these drugs. And there is the fact that the incidence, the occurrence of new cancer patients has been constantly increasing since the last 30 years, from 270,000 patients to 430,000 patients. But you can also see that the growth rate is declining. So at the moment we are at a growth rate of 1%, and if we look at the prognosis of the incidence of cancer patients in the future, now we see 10 years slices. There will be an increase, but this increase will stop after the year 2030. If we assume that ceteris paribus, the incidence rates are the same as today, but there's also a chance that they will be lower, so that this prognosis is an overestimation. So, but we can see that the increase of new cases will be stopped when the society comes to a stable demographic situation in around 2030. This might not be the case in every European country, but in the long run, I'm sure that the majority of countries will share this situation. Now I come to the pipelines. Will there be a huge number of drugs? This is how it was in the 2000 years of 2000, and within this period of time, we did not observe an increase of new drugs. We had in the first half, we had registration of around 3.2 drugs per year, and this was exactly the same in the second half. So in that decade, there was not an increase of new drugs, and we looked until 2013, and we found these 12 candidates, so that this is for the next period of 4 years. This equals an introduction of 3 new drugs per year, exactly the same amount that has been introduced in the 2000 years. So pharmaceutical companies, in their investor relations, they talk a lot about new drugs in the pipeline, but unfortunately for them, when it comes to market, the number of new entities is amazingly low over the years, and I assume that there will be not a considerable difference in midterm. Now we come to the prices. The prices are very high, and this has been pointed out in this report commissioned by the Ministry of Health in Germany, and on the first pages there were listed the prices for a 1-year therapy with drugs that have been discussed here, and this issue that the therapy of 1 year costs more than 30,000 euros or more than 50,000 euros. This has an enormous emotional impact on the discussion, mainly for physicians, because sometimes I have the impression that they envy the pharmaceutical industry, that they can earn such a lot of money where they have to work for little money. So, and I want to address the issue of setting prices for, let's say, for infrastructural investments. And therefore I show this bridge because it's an infrastructural investment, as well as a drug is an infrastructural investment, because a pharmaceutical company is only doing everything to bring it to market and then lose the right to market it exclusively when the patent runs out. Then the bridge, the pill, the drug is free, and therefore we have to consider the financing of a bridge the same way as a drug. And because it's less emotional, I switch to the bridge now. Let's say we have a bridge here in Nevada which costs $100 million to erect it. Then we have another $50 million to pay the interest, because the construction of the bridge takes several years that have to be financed, and after the first car is paying toll and going over the bridge, all the investment is not paid, and we have to pay back the money, the debt, but also the interest, and this might be $50 million, and then we have to maintain the bridge, look after the bridge for, let's say, for 20 years, which costs $40 million. So we have, for this bridge, for the use of this bridge for 20 years, one has to spend $190 million. And now comes the question, how is this going to be paid back? I assume that there is a toll financing, so one has to, for each passage, one has to pay. And now we see something trivial, but it's worth to think about, that the number of passages per day is the driving factor for the price per passage. If 10,000 cars go over this bridge per day, the toll is $2.60, which is something one would expect if the alternative is to drive 15 miles down and 15 miles up. So, but if the toll would be $26,000 and the answer of the drivers would, I assumedly would be no, that is not affordable. But a drug at $26,000 is affordable, and this is because healthcare systems, either tax-funded or insurance-funded health systems, equalize these costs and distribute them to those who are not sick. And therefore, we have to ask what are the costs for a drug that sum up in the period during the drug is being developed and the drug is being sold. And we see that, that it is a list of variable costs and fixed costs, and fixed costs have the let's say the property that they have to be paid either if you sell one pill or if you sell billions of pills. They are so-called sunk costs. These costs have to be paid either if you sell the drug, or the drug will not be licensed. And if we look at these sunk costs, we see that it is a sum of yearly expenditure for, let's say, on average 8 years, of around 50 million euros or dollars, which is an average drug development cost. But it's not only the drug cost, it's also the interest that has to be paid for the money that cannot be active for 8 years. And together we have a debt at the end of the development phase. There is a debt of 760 million euros. This is the same, the parallel to the bridge where we have $150 million to be paid now from the toll. And now the same, like the passages over the bridge, happens with the drug. There is a strong relation of the drug price that has to cover the sunk costs and the numbers of patients that are eligible for these drugs. And if we have 100,000 patients per year in this example, the drug costs are 950 euros. If we have 1,000 patients per year, the drug cost per patient is 95,000 euros per year. And now the question is this obscene or is this not obscene? I think this is not the question. The question is how the amount of money that has to be invested for development of a drug that goes to public use after the patent is run out has to be refinanced, and this is a question of the number of patients that are eligible for that drug. And to add this, all what we're talking about, targeted therapies or personalized medicine, will more and more shrink the numbers of patients that are eligible for a new drug. If we divide breast cancer into 5 or 10 entities, and every entity has a special treatment, the drug costs are allocated to a shrinking number of patients and will go up more and more. So, but this is not for reasons of exploiting the desperate situation of patients. This is just economy. Now I come to the last question. Will that all cause an avalanche of costs and attack the sustainability of the healthcare system? And we are in the favorable situation that we already can observe this phenomenon. At least after 2005, a lot of very costly drugs have been introduced to the German market, and we see that today, or 2011, we have a share of expenses for drugs at all services of the healthcare system of 17%, and this was around the same in 2002, 2001. So over a period of 10 years, there is not a change unless you see this. After 2005, there is a little increase from 18 to 19%, and we look now on the special diagram for cancer drugs, and this shows that we have indeed we have an increase from 2005 to 2009 from 7.3 to 9.4% of the share of cancer drugs on all drug expenses. So we had quite a let me go back. It's not a. Oh yeah, let's go back. We had this. We had a very strong growth in the first years from 2005 to 2009, and this could explain why we had this little growth from 18 to 19%, but this has been resumed. We are down at 17%, so we cannot observe this destabilizing situation. And if you look to single drug segments of the cancer drug markets, we see that in established cytotoxic drugs there is no increase. There is a decline in drugs, in hormones that are running out of patents. We have very, very little amounts of drugs used in certain groups, and we only have 11 drugs that show a significant increase of costs, and again only imatinib and rituximab show an unbroken increase in that period of time. So all over we see that conventional cytostatics and hormones are more or less stable in their use and their expenditures. The monoclonal antibodies and the TKIs, they have been increasing in the first 5 years because of they were novel, and they saturated now the patient populations, and the increase rate, the growth rate since then has been much lower than before. The growth rates, again, all over, we had a growth rate of 15% in 2006, 2007. We are now at 3.4%, and in 2012 we will be at 0% because of additional measures of the German government. And for monoclonal antibodies and TKIs, there indeed has been a growth of 50% per year in the years 2006, 2007, and this might have been caused the impression that we are rocketing without break. So, thank you very much. I think the situation in Germany is comparable to other countries. We haven't explored that yet, but for the next years, I would say there is no reason to fear an end of the sustainability of the financing of the healthcare system. Thank you.